questions, things over here. All right. So sepsis is a very important disease condition that we have in ICUs, and mostly most of these patients 3 times get admitted to a rehabilitation center. Even if the sepsis mortality is coming down. See, over a period of time, we've realized how to tackle sepsis and get them out of the hospital. But importantly, we are still finding almost 3 times the number of patients getting admitted to rehabilitation centers. That is very, very alarming. Second thing is that, when we are actually having, even though the sepsis mortality is down, the death in the first year has increased by more than 50%. The first year, that means the patient goes home and then dies after in the first 50 years. 1 or 2 dies in the first 50 years. And importantly, the 6-minute walk test, which is an indication of function, that actually goes down to almost 70% even
Sanjit,
at 5 years.
sorry to interrupt. Your voice is cracking. Can you just recheck your audio settings once, please?
1 second. 1 second. Audio settings. Okay. Okay, wait 1 second. I'll do one thing. Okay, is it still bad?
Better.
Now it's okay. Yeah.
Yes, better, much better.
Actually, what is happening now? Somebody has put me as a admin,
Co-host.
so and that's what's causing the patient. People are getting admitted, so I'm trying to admit them, and this is what's happening basically.
Okay. Okay.
Sir, I'll admit everyone, sir. I'm doing it. Because of the co-host settings, you're also getting the notifications.
So that's what's basically.
So can you just remove Sanjit as a co-host?
Sure, sir. Sure, I'll do that.
Yeah, just remove Sanjit. Let him just speak.
Okay, am I clear? Am I clear now?
Yes, sir.
So do I share my screen again?
Yes, sir.
So I'm unable to share my screen now.
So now you can share your screen.
Okay, 1 second.
Sir, my request, sir, you can ignore the notifications, sir. Sorry.
No, please remove Sanjit. Please remove Sanjit as a co-host.
Sir, then sir won't be able to share the screen.
Okay.
Sorry, sir.
And you please take over the job of admitting people.
Yes, sir, I'm doing that. But even the co-host will get the notifications. So.
Sanjit, just ignore them.
Yes.
Yeah. So can you hear me now? Can you hear me well?
Yes, sir.
All right. So let me just, I don't know where I was. Okay. So what's happening is, even though the sepsis mortality has gone down, even though the sepsis mortality has gone down, the 6-minute walk test at 5 years hasn't changed. That means almost even at 5 years, only less than 70% of those people actually are able to complete a 6-minute walk test. This means to say that we are doing something wrong somewhere. And that's what happens over here. There's ICU-acquired weakness, and recovery from critical illness is something that has become is the latest term in the last 7 or 8 odd years, where we know that patients are coming out of the ICU but are not going back well home. It is so difficult if the person can go home but not able to even switch on a remote control. I mean, that's something that we don't want. We want our patients to do well and go back home well. This is very, very important. So let's start thinking as to what's happening over here in our cases of critically ill patient. Now, a critically ill patient is a very, very all-inclusive kind of a disease, the response of which can be much, much characteristically the same. However, the intensity is what is normally changes. It can be a low intensity, it can be medium intensity, it can be a very, very high intensity. But common to all is a drop in the amount of skeletal muscle mass. This is very clear. There is a drop in the skeletal muscle mass in these cases, and an alteration in the glucose metabolism cycle, where there is an increased amount of glucose, especially because of this particular enzyme pyruvate and acetyl coenzyme. This particular chain is not working very beautifully, and this per se does not change with insulin. In fact, addition of insulin will actually cause reduced lipolysis, enhanced lipogenesis, and anaerobic glycolysis. So there is a large amount of problem that is occurring in critically ill patient, and this is just a small change that I'm telling you. And if I were to actually look at it clinically, it is like a storm. I mean, you have two phases, a surge phase and a Kars phase. Now it is, at the moment, we know it's more like a dysregulated adaptive immune response that you see in patients of sepsis. So in short, it's a storm and things are just going haywire, metabolically getting deranged. And that is the reason that critical illness is like this kind of a monster. I feel it's a great monster. And if I would actually go back to a study almost 20 years ago, Lindsay Plack from Auckland Hospital, New Zealand, actually looked at a beautiful study. They looked at sequential changes in the metabolic response in severely septic patients during the first 23 days after the onset of peritonitis. Let's go into what they looked at. So what they found was, let's look at this graph. They found that in the first few days, the resting energy expenditure keeps changing near about up to almost 9th to 10th day, after which it slowly starts reducing. I mean, it goes up, goes haywire, and then it goes down. But if you were to actually predict it by any of the predictive equations, we probably just have one straight line. This is what Lindsay Planck actually proved. Importantly, it's somewhere around 9th to 10th day that there is a maximum amount of resting energy expenditure in post-operative patients, is what it appears, at least by this study. But it's certain that it's not one particular number. There are different numbers that are occurring. So if you were to actually look at patients in our ICUs, there will not be one particular kilocalorie per kilogram. It is going to be different kilocalories per kilogram at what it appears. But after 10th day or so, it kind of becomes slowly coming down up to day 24 is what it looks like, at least by this study. Now let's go back to this particular graph. On this graph, on the left side, you're seeing CRP and pre-albumin. And on the right side, you're seeing transferrin. And down, you're seeing the study days. Now, if you see very carefully, what is happening over here is that even though the CRP has come down, the CRP has come down majorly at 21 days, even then the albumins, pre-albumins, and the transferrins have not even reached even near to normal, indicating that there is still a catabolic response that is occurring, which does not even become okay even at 3 weeks. In fact, we have studies that say that the catabolic response go on till 3 months after a critically ill illness. Now, let me explain to you what's actually happening. What you're seeing on the red line is actually the homeostasis. I mean, body fights its level best to maintain the vitals, maintain the breathing, maintain the blood pressure, pulse rate, and that's called homeostasis. And when the patient actually gets a little bit sick, it goes to an elevated state of homeostasis, and that's called the new normal or the allostasis. So all of us go between homeostasis and allostasis in all practical reasons. We go between the normal and the new normal whenever there is sepsis. Now, let us take the example of this particular patient. This was a healthy patient who basically had some kind of initial stressor, which may be sepsis, and on ICU of day 3, his homeostasis went from homeostasis to allostasis. This is what it looks like. It went to allostasis. Now there, if we now put an allostatic overload, if you have an allostatic overload, then it is going to take a very long time for this patient to come out of it. And this is that patient that will go into extreme critical illness, neuropathy, myopathy, or the chronic critically illness phase that we talk about, that I mentioned at the start of the lecture. Well, how do you induce this allostatic overload? Yes, you induce this allostatic overload either by underfeeding or by overfeeding. There are only 2 reasons why allostatic overload will increase. It is underfeeding or it is overfeeding. Well, does it occur? Yes, we have data that actually says that overfeeding is harmful. Look at these 3 failed weaning attempts. This is a paper that came out from my hospital, which actually said that there were weaning attempts at the end of 2 weeks. And that's probably because of the fact that there was overfeeding, which we corrected, and then the patient was successfully extubated. Well, even after knowing all this, we know very clearly that the number of patients who are actually malnourished, at least in our ICU, is very high. Almost 67% of males that admitted to our ICU and 71% of females admitted to our ICU were in the high risk group. And I think that almost everyone across the country will have similar numbers. There are no other representative numbers, so I've put up the data from my hospital. This is a study that we published, where the mortality per se has been definitely high, close to 30% in these patients who are from the high-risk group. So there is pre-existing malnutrition in most of our patients, is what it appears. And there are huge challenges in the delivery of nutrition, is what I feel. I mean, this is another study that we did in the city of Mumbai. And look at the type of first feed used in hospitals. Water, bed elevation monitoring, scientific feeding formula is used less. Challenges in achieving calorie requirements are very high, is what it appears in most of our ICUs across the city of Mumbai at least, and the use of scientific feeding formula are definitely less. On top of it, we also showed that the mean percentage protein and calorie deficits were almost to the tune of 40% to 50%. What does this mean? That we all are doing nothing to avoid the catabolic nature of this particular disease. We are not doing anything to prevent the skeletal muscle from breaking down, nor are we doing something for it to rehabilitate faster. The answer to all this is actually nothing but giving adequate energy. That is the answer. The answer is to give adequate energy to these particular patients so that these particular catastrophic abnormalities do not take place. Now, the big question and the topic for today is, how much is the energy that we require? That is the biggest question. How much is the energy that we require for these particular patients? So to find out these methods, there are so many methods to figure out what are the various ways to figure out energies: direct calorimetry, first beat by beat method, double label water, wearable devices, heart rate based energy expenditure, MedGem like devices. But the topic for today is either indirect calorimetry or predictive equations. These are the things that we use again and again: predictive equations and indirect calorimetry. Let's go to predictive equations. Look, there are so many equations. There are more than 200 equations in the market, which actually tells us about energy expenditure. But however, what is now we are using on a regular basis is simple predictive equations, as simple as a number as 25 kilocalorie per kilogram. So that means to say that if a patient comes into the ICU, I will start at say 15-20 and reach up to 25 to 30 kilocalorie per kilogram by the end of the day. If it was so simple, I would be probably just resting and not even taking this particular lecture. But it is definitely not simple. It is not as simple as it looks like. Let's take the example of a patient. Let's take the example of this patient who basically got into the hospital with respiratory distress. Regular patient got intubated, had inotropic supports, intestinal obstruction, then underwent an exploratory laparotomy, renal failure, went into CRRT, and then a high output fistula. How can the whole kilocalorie per kilogram or the prescription of kilocalories will involve only 25 to 30 kilocalorie per kilogram? It is going to be variable. There are going to be phases where it's going to require less, where it's going to require more, and somewhere where it's going to require really, really high amounts. Of course, this will come to we will understand this only when we measure what we want to give to our patients. So let's look at these patients. We believe that our patients are something like this, the blue line over there. That is, if we predict the energy expenditure, say at 25 to 30 kilocalorie per kilogram, our patient will lie on that particular blue line. However, that is not what our patients are. Our patients are this way. Over a period of days, they keep changing. And this is one of the patients that we've done in the past. A simple, regular, healthy patient. This is not a patient who was sick. A simple, regular, healthy patient who was put on a ventilator put on the ventilator post-operatively and just took an extended duration of stay because of the fact that we weren't able to wean them off. And this is what we found. We found these patients were having different kind of energy expenditure all throughout the stay. And some patients are like this. It is depending on the length of stay or even the Apache scores, there are no relationship. This more severe, less severe, more days, less days, the energy expenditure is just off the hooks. It cannot even predict it by any kind of method is what it appears. So what is the actual energy expenditure that we need to give that we need to prescribe to these particular patients? Well, Oren Zussman in 2016 had this brilliant study that came out to explain how much we should feed these patients. So this was a group of 1,171 patients that he looked at retrospectively, and they were reasonably sick kind of patients, which involved surgical trauma, medical sepsis, respiratory and cardiac patients over here. And the Apache scores were near about 22 overall. That's quite high, quite a sick group of patients. What he did find was that the resting energy expenditure on an average was 1,944. And when they actually tried to predict it with an equation, it was nearly 400 kilocalories more is what it appears. But then when he did a Cox proportional regression analysis, what he found was that as you actually, what you're seeing on your y-axis is the unadjusted odds ratio for 60-day mortality, and what you're seeing on the x-axis is the delivered calories divided by the resting energy expenditure by indirect calorimetry. What he found was, as you actually reduced the delivered calories with respect to the resting energy expenditure, I mean the percentage of delivered calories, there was a reduction in mortality. And up till you reached somewhere around 70% is what it appears, somewhere around 70%. After that, there was climbing up of the mortality again. That means to say, if you feed approximately 70 to 80% of the resting energy expenditure that you have measured, there is a high possibility that the mortality will probably reduce. And if you were to feed 100% of the resting energy expenditure, or rather more than that, probably there is going to be an increase in the mortality is what it appears, and that doesn't hold the same for proteins. In fact, if you keep on giving lesser proteins, the patient's mortality does go higher is what it appears to be. Well, very much this, that means to say 70 to 80% seems to be the safe spot of the resting energy expenditure if you want to actually feed your patients adequately. Now remember this 70 to 80% is that of the measured resting energy expenditure. It is not from that is calculated. That is why we say that approximately 70% is the right zone to improve survival, whereas anything more than that, up to 130% or much lesser than that to 30%, is probably going to cause death, is what it appears, at least by this particular data. Now, importantly, look at that. 1944 is the resting energy expenditure mean, whereas in Harris-Benedict's equation, that is a predictive equation, it is 2304 is the mean, which indicates that in no way you can actually predict the resting energy expenditure in a critically ill patients, is what it appears. In fact, in another study that was done by Peter Weiss, if there was no energy deficit, the mortality was very high. In short, it does appear to say that if you know exactly what you're feeding, if you know exactly how much you're supposed to feed, you will probably feed around 70 to 80% lesser than that and probably affect mortality. Compared to that, if you were to feed the entire amount or feed somewhere around 20 to 30% more than that. Very clearly, this it was the same throughout different categories of patients, septic, non-septic, non-overfed, all patients, we found the same thing. And in another study that was actually done by Babbitt, all the other equations were also looked at, and they found out that all equations either underestimated or overestimated the amount of calories that are required when you compare that to resting energy expenditure. Well, we did a study recently, energy expenditure in COVID-19 mechanically ventilated patients. Now remember this is a group of patients that are the same pathology, COVID-19 mechanically ventilated patients. I would reasonably assume that if I knew the weight of the patient, which we had because we have weigh beds, I would probably be able to predict each and every patient's kilocalories, in which I thought was anywhere between 25 to 30 kilocalorie per kilogram. And we monitored all these patients. We monitored a good number of patients, 172 patients, for their resting energy expenditure via indirect calorimetry. And what we found out very clearly, there is no relationship to the predictive equations at all. In fact, even at 3 days or 4 to 7 days or more than 8 days, the mean energy expenditure by indirect calorimeter was completely different as compared to that seen by weight-based equations. In fact, they differed by more than 1,500 kilocalories per day, which could amount to a great amount of energy deficit, or for that matter, great amount of energy overfeed. Very clearly indicating that to predict means you are not doing anything, and you have to measure the energy expenditure in some way, is what it appears. Concluded this particular important paper by saying the energy estimated with EeVCO2, that is carbon dioxide from the ventilator, volumetric, correlated better with IC values than energy derived from weight-based calculations. Our data clearly suggested that use of simple predictive equations, the one that we mentioned as 25 to 30 kilocalories, may potentially lead to overfeeding in mechanically ventilated patients with COVID-19. Very, very important statement that we made in a study that we recently published in the ISPEN. Well, what is this indirect calorimetry? I mean, you're hearing from me since the last 15 odd minutes about this particular thing called as indirect calorimetry, and I'm glad that Ghanshyam invited me to take this talk, because of the fact that there are very few people in the country, and I hope many more people start using indirect calorimetry. Well, what is this? It is nothing but if there's a cell, the cell has to take in oxygen and it has to breathe out carbon dioxide. When it breathes out carbon dioxide, this particular device measures the expired volume of oxygen, measures the expired volume of carbon dioxide, measures the inspired volume of oxygen, inspired volume of carbon dioxide, and then puts it into an equation. And this is the major equation that we talk about, the Weyer's equation, where VO2 is the oxygen that is getting consumed, whereas VCO2 is the carbon dioxide that is getting produced. And when you use these particular data that comes in from the ventilator or from the device indirect calorimeter, we get the VO2 and the VCO2, and thus we get the resting energy expenditure. Now, there are many devices that have been using this. There are devices in which you can use it in spontaneously breathing patients. There are devices that can be used in ventilated patients. There are devices that are portable. There are devices that are handheld. there are devices that are being developed over a great stage of development, and there are devices that are made by doctors ourselves. And the latest device that is made by doctors ourselves is the iCalic device made by the iCalic investigator called as the COSMED. The ones that I'm showing on the screen is the one that is used for on the ventilator. This is called as the CareScape R860 ESCOVIX module used for measuring resting energy expenditure. The only thing that you have to look at when you are actually monitoring indirect calorimetry is that it takes some time to warm up. Whereas the new iCalic device, the COSMED device, does not have any time to warm up. It just warms up immediately. Calibration may be required in the older generation of these particular models, but the latest generation don't require even calibration. The important thing that you have to figure out is there has to be no leaks in the system. This means to say that if the PEEP was very high, that is more than 10 or 12, there is a chance that there may be small leaks that might occur around the tube. Even that leak is not supposed to occur. If the FiO2s are more than 0.7, they probably don't give the right results. And that's why we have to ensure that the FiO2s are less than 0.6 or 0.7 when we're actually measuring resting energy expenditure. There has to be no oxygen fluctuation, and the resting energy expenditure has to be maintained has to be monitored at that time when there is absolutely no changes in the hemodynamics. That means the ventilator settings are not changed for at least 1.5 hours prior to that. There are no hemodynamic instabilities that are seen in these particular patients. There are no changes in the noradrenaline that is done. That is when you are going to actually measure the resting energy expenditure. It's important that you don't measure it around the time of a bolus feed also, because that will also alter the resting energy expenditure. In short, we need to measure the resting energy expenditure of the cell in the body, and that is possible only when there is a maintenance of a steady state. And when I mean steady state, means almost an hour of no change in ventilator settings, no change in the hemodynamics, no change in the oxygen, and absolutely no leaks. Patient should not have pain and should not be slithering around. That is the time when you need to monitor these particular patients. Now this has become even much more simpler in the newer generation models called as the QNRG Plus, where the warm-up and calibration time are hardly there, and you can even monitor the indirect calorimeter resting energy expenditure even if the FiO2 is approximately 0.7. Well, it's a great form of monitoring resting energy expenditure. Whenever we talk about this particular topic, and whenever I've been talking about it, the first thing that comes to everybody's mind is there any evidence for this indirect calorimeter? Well, let me try to dig up some evidence from here. Let's see three important trials: the EAT ICU trial, the TICACOS trial, and the Heidegger trial. What was clear is was that by one of the trials was early goal-directed nutrition therapy directed by indirect calorimetry was not better than simple weight-based equations. Now, how can that be so? Because that particular trial actually did overfeeding. They fed their patients to 100% of their requirements as measured by resting energy expenditure, and that is not what we do. Early full nutrition, whatever the route, is harmful, associated with more hyperglycemia, infections, and organ dysfunctions. Hence, that particular trial, which actually looked at early goal-directed nutrition directed by IC, went on to say that it is not better than simple weight-based equation. It will not be, because you fed their patients with full nutrition. That is not what you have to do, because full nutrition is not where it's supposed to be, is what we know from the Zussman study, which says we have to give somewhere around 70 to 80% of the resting energy expenditure. Well, that was the EAT ICU trial. Now, the TICACOS trial actually showed a trend for a lower mortality when in those patients that were given calories or energies based on the IC guidance, that is based on indirect calorie guidance, very clearly showing that there was a trend towards a lower mortality, at least in those particular patients. When Heidegger trial very clearly showed that for fewer nosocomial infections, the very, very important nosocomial infections is the one that actually increases length of stay. That is very, very important for us to understand. And they also showed a trend for a lower mortality in the IC guided group versus the control group as seen in TICACOS. They actually showed the same thing also in that particular study. This is another study that was done where they monitored these patients with indirect calorimetry. A good number of patients were monitored here, 563 versus 527. At first, a retrospective kind of study. There again, they found that the ICU length of stay did come down, is what it looked like. Another study that was published in 2021, that is just some 1 year ago, it actually showed that when they looked at approximately 8 records. They looked at all these particular studies together. What they found was that indirect calorimetry guided energy delivery significantly reduces short-term mortality in critically ill patients. That's the reason that they said measured resting energy expenditure should replace conventional practice of calculation-based resting energy expenditure is what it appears. Is it something like this is seen in our hospitals also? Yes, it is very clearly. Look at this particular data. This is a patient that was admitted into the ICU, and we were trying to wean off these patients. We were giving this patient 25 to 30 kilocalorie per kilogram on a daily basis, and we thought, why is this patient not improving? Why is this patient not getting weaned off the ventilator? We had 3 successive failed weaning trials, and we thought that we probably heading the wrong way. That is the time that we actually use indirect calorimetry. The yellow mark is where we use indirect calorimetry, and we found that we were actually feeding our patients at least 800 kilocalories in excess. That is when we actually reduced the feeding, and within the third or fourth day after this patient was successfully extubated, clearly showing a proof of concept that indirect calorimetry can also help in weaning very clearly. Well, this is another study that we did. This is a good number of patients which we divided into 2 parts, 83 patients who versus another 83 patients who were monitored by indirect calorimetry, and they were for all sorts of diagnosis: sepsis, COPD, stroke, ischemic heart diseases. The comorbidities were kind of equally distributed between them, with diabetes, hypertension, COPD, and ischemic heart disease. Also, their severities were quite high. Above 23, we had 20 of these patients, and 15 to 23, we had 44 each in each of these groups that were monitored with and without indirect calorimetry. This has just been published last month. And what we did find was, when we actually divided these patients into those patients with indirect calorimetry and without indirect calorimetry as a whole group, we found that in the category of patients in the Apache scores between 15 and 23, there was a significant drop in the length of stay in the ICU. Very, very important result that we got in our study. Importantly, we also found that the length of stay on the ventilator was much lower, almost 3 days lower than those who were guided without indirect calorimetry, and this was more significant in those patients who are at risk for malnutrition. So this means to say that the category of patients in which indirect calorimetry should be done is those patients who are reasonably sick and those who are at high risk for malnutrition. It is there where there is a drop in the length of stay in the ICU and length of stay on the ventilator. And I'm certain that there would be also changes in mortality if we had a larger group of patients, is what I feel. Well, this is another beautiful data that comes out from the Jewish hospital in the United States, where they actually had two periods of care. One period of care was when they did not use indirect calorimeter, and the other period of time was when they started using indirect calorimeter, and they just looked at their average ventilated length of stay. So look at this: the average ventilated length of stay versus the average ventilator length of stay after they actually started indirect calorimeter. It changed by a good number of days, is what it appears. In fact, even the ICU length of stay changed by a good number. Almost 3 days change in the ICU length of stay is what it appears. Half a day reduction in the average ventilator days and almost a 3-day reduction in the ICU length of stay is what it appears to be. And look at the cost that they probably saved. They saved a huge amount of cost. Almost $10,000 per day per patient was saved when they actually use indirect calorimeter. So not only does it become cost effective, it also reduces length of stay. It also reduces average ventilator days. And I'm certain that it probably may also change mortality if we had larger number of patients that were enrolled in most of our trials. Well, what seems to be our common goals? Our common goals is somehow to give the best possible care to our patients. And there will be a time in the future where our patient will tell us, do not just give me anything, give me what I need. And to give them what they need, we actually need to measure what we are supposed to give them. And that's the reason that we should personalize. We are giving personalized t-shirts, personalized pens, even our mobile phones are kind of personalized. How don't we personalize our kilocalories that we are giving our patients? I don't understand. How can we want 20 to 25 kilocalorie per kilogram to every patient that are there inside the ICU? Because they have got so different kind of metabolic picture. It is just not possible to just have one particular number for a particular patient, even for a particular patient for a particular disease. Do we monitor? Do we actually titrate our vasopressors without monitoring? Do we do that anytime? I don't think we do any of these. We don't titrate any of our vasopressors without monitoring. So how can we then titrate our energy expenditure. So the ball is in your court. You must decide whether we should be monitoring energy expenditure by indirect calorimeter. And I think that's the right way to go ahead in these particular patients. Hope that I led you to some kind of the sweet spot over here. All these slides are available on drsanjit.com, and I'll leave you with these guidelines that clearly mentions that in critically ill mechanically ventilated patients, energy expenditure should be determined by using indirect calorimeter. If calorimeter is not available, they still say try to use VO2, that is oxygen consumption from pulmonary artery catheter, or VCO2, carbon dioxide production derived from the ventilator. Even that will give a better evaluation than predictive equations. In fact, they say there is no mention of using a predictive equation at all in any of this particular guideline is what it appears. In fact, predictive equations should not be used is my important suggestion in this particular talk. In the SCCM as well as the ISPEN also says the same thing. We suggest that indirect calorimetry be used to determine energy requirements when available, and in the absence of variables that affect the accuracy of measurement. That means we have to use IC is what is very, very clear. Well, people would say, I think by now, most of us would agree to the fact that indirect calorimetry is the gold standard. IC has become quite easy to perform, as I showed you. Predictive equations by multiple data, even some data from our hospitals, clearly indicates that they are not great. There are many other uses of IC which actually is beyond the scope of this particular lecture. Guidelines and experts love it. I can't do without it. And I think all of us should not be able to, should not prescribe nutrition or kilocalories unless we measure what we are supposed to give them. Thank you very much for the patient hearing.
Thank you, Sanjit. I think you touched upon certain very, very important aspects about the energy requirements and how do we go about addressing this very, very pertinent issue in the intensive care unit. I totally agree with you. Something which should be given unmeasured is love, right? And yes. Even that sometimes can be not the best of things. But when you want to feed your patients, and we all being people who are interested in nutrition do understand the fact that until unless you measure what you're supposed to give, there's every possibility that you can always get it wrong, right? Yeah. So I open the session for any doubts or queries. Please type your questions in the chat. Sanjit, sorry. Hello.
Yeah, I can hear you. I can hear you. Sorry.
Yeah. So did you get the first question?
What was the first question?
The first question is, how frequently would you recommend doing the indirect calorimetry?
Well, fantastic question. So this question comes with the thinking. I think what the delegate is thinking is that, throughout the day or 2 days, there would be change in the metabolic expenditure. There would be change in the resting energy expenditure. So shouldn't we monitor it daily? That would be the first question that comes to you. Well, what is clear is if the length of stay is less than 5 days, if the predicted length of stay is less than 5 days, you need to monitor it only once in that 5 days. Because what we must understand is if we are going to change by more than 4,000 kilocalories, that is where the survivability change or the adjusted odds ratio for death increases. Now, If the patient is going to stay for more than 5 days, then we need to monitor indirect calorimetry once every second or third day. That means every third day monitoring is what is required if your patient is going to stay in the ICU for more than 5 days. I hope that answers the question.
Okay. Sanjit, we have one question from Srilata. For geriatric patients, do we need to detect 10% of the RDA if we are following the ISPEN 2022 guidelines for energy recommendations, that is 12 to 25 kilocalories?
So first of all, even if it is a geriatric patient, it is very, very important to actually monitor resting energy expenditure. In fact, it is that patient in which I would monitor it maximum. You will not believe it. Almost 37% of our patients have got free fat mass that is much, much higher than we have expected in the first place. And geriatric patients have got extremely low lean body mass, extremely low lean body mass. They come to phase angles of somewhere around 2.4 and 2.5 when we actually do bioelectrical impedance analysis. And that is one of the prime areas where we must actually use energy expenditure. Geriatric patients, because these are those patients in which if you underfeed or you overfeed, they will not do well. And any of these equations, 12 to 25, the range is just too much. It's not something that we should use. We have to use an IC data to actually understand this. But if you were to not have IC, then what you do? You probably err on the safer side by giving somewhere between 12 and 15, because we know overfeeding in these patients are much more dangerous than underfeeding.
Okay. Again, a very, very practical question, Sanjit, from Kavita Chindil Kumar. What do we do where we don't have indirect calorimetry? And that seems to be a very, very common problem across the country. I mean, not every center has that.
This is something that that I get asked every single time that I deliver a talk on indirect calorimeter. Yes, I will again reiterate the fact that the gold standard is IC. Now, if you don't have IC, what do we do? The next easiest option that you can think of is by actually doing a VCO2 estimation. That is a volumetric capnography that can be done, and we can find the volume of the carbon dioxide that is coming off. This is available in many ventilated patients. That means invasively ventilated patients. There are certain ventilators that give you VCO2, the Hamilton G6, the GE Healthcare ventilator, the new Draegers, they give the VCO2. With that VCO2 into 0.85, you will still get nearer to the energy expenditure if you don't have the indirect calorimeter. Of course, that is not as accurate as that of the IC, where you're monitoring respiratory quotient as well as VO2, but it goes nearer. Now, if you don't go that also, then the other option is to actually put in a pulmonary Swan Gans. Now, nobody will do a Swan Gans to actually figure out calories per se, but if you put a Swan Gans and you find the VO2, you can actually use the VO2 to actually figure out what your energy expenditure should be. Otherwise, you are left with the situation to actually give somewhere that is similar to the simple predictive equations, which include 25 kilocalorie per kilogram. But on that part, I would probably say on a mechanically ventilated patient, the Penn State equation probably is the closest that you can get to the indirect calorimeter data that at least from our studies that we have done in the past.
Okay. Sanjit, you have one more question. Well, for the energy requirements, yes, we have kind of there is a recommendation for using the indirect calorimetry. What should be your ideal protein requirement based on the lab reports? I mean,
so we don't really use the lab reports for protein requirements at all. In fact, we would never do that. What we normally do in these cases is we actually use our bioelectrical impedance analysis machine, and we figure out what the lean body mass is. So if the lean body mass is on the lower side and this patient is at a high risk for and the appendicular fat mass seems to be skeletal mass is lean body mass is actually on the lower side, then we try to err on the higher side by giving somewhere around 1.5 to 1.8 gram per kilogram in the ICU, reaching at least 2 to 2.5 gram per kilogram by day 5, day 6. See, the first 4-5 days, now there is not going to be much of a difference. It's very important for us to understand. The critical care is not, nutrition is not defined in the first 4 or 5 days. Unfortunately, we start thinking about critical care nutrition in the first 3-4 days time, but that's not where we think about it. Everything is all the ball game starts changing somewhere at 5th and 6th day, and it's a long-term kind of care. So when you say critical care nutrition, it starts in the ICU, no doubt, but it ends 2 months later. So that's what we must understand. The critical care nutrition should start early, and this protein intake that we're talking upon has to be on till at least 2 to 3 months of time. That is when you will see changes. That is why most of the studies that have aborted at 28 days have not really found much changes per se. But if you look at 3 months, 6 months, Kathy, Alberta, all of them have found some kind of change in respect to mortality and functional status. So yes, protein should be on the higher side, 1.5 to 2, but that doesn't mean you'll give more than 2.2, 2.4, because we know that above that, it causes more amount of problems.
Yeah. From Sarupa, can we do this with the help of ABG? I think she meant the carbon dioxide that we get from the ABG.
No. So that that cannot be done. That cannot be done at all by ABG analysis. That is partial pressure. We will actually need to do a Swan-Ganz analysis. That can be done. And there are certain ventilators which actually operate on the fixed principle. There are ventilators that give you PO2, PCO2. There, when you enter the ABG PO2, you may get by fixed principle a cardiac output and then an energy expenditure through that particular. But the fixed principle is supposed to be very, 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 very naive when you compare that to indirect calorimeter.
Yeah, from Srilata Sanjeet, for patients with CKD or CLD who are malnourished, and if you don't have indirect calorimetry, do we simply follow the 15 to 20 kilocalories formula?
So I am just in the middle of a study which is actually looking at BIA and resting energy expenditure in dialysis patients. We've just finished 84 patients as of now. Today was the 84th patient, and we are looking at resting energy expenditure. And at least from my analysis, interim analysis at 50 patients, I'll tell you it's not easy. It's definitely not easy. We are seeing expenditure of patients right from even as low as 700 kilocalories to as high as 1900 kilocalories. So this 15 to 20 kilocalories, I don't know how can I interpret this when I'm actually looking at. The more I'm studying, I see the more I'm getting confused. The more it's making me difficult to live is what it appears, because it's complete across the board. But what I can tell you for certain is, see, you have to err on the lower side with calories, not on the higher side. So contrary to views, you might think that a CKD patient is on dialysis and maybe hypermetabolic. That is not what I am seeing. What I am seeing is those patients who are on dialysis are still actually on the lower side of their kilocalorie requirements. So they actually require much lower. The body is a very clever organism. The entire body is so clever that it goes into this hypometabolic phase every time that it is stressed, rather than it becoming hypermetabolism. Remember this, endogenous glucose production is always there. In fact, every time the patient gets metabolically abnormal, endogenous glucose production starts, and we end up by giving calories and actually causing a drop in the autophagy, which is actually the mechanism that is preventing you from getting worse. So that's the reason that underfeeding still would be a better bet than actually overfeeding. And when I say underfeeding, it doesn't mean underfeeding proteins. It means underfeeding the calories.
Yeah. One question from Kavita about burns patients, right? Indirect calorimetry, if it's not there, right, and then how would you?
So I just did one patient of burns. Okay, so let me tell you, I did just one patient. One doctor from ONGC from the burns area. They actually happened to call me, and they wanted to know the energy expenditure in one of their patients so that they could use it that as the benchmark. So yeah. I went with my machine to that area to figure out what should be the energy requirements. And what I found was it was alarmingly high. Very, very alarmingly high. It was close to 3,700 kilocalories per day is what I figured out in that particular patient. Of course, that patient was in the 7th or 8th day after resuscitation. And what I've noticed was that, contrary from other patients, in critically ill patients, on the 7th or 8th day, you have it peaking and then it starts coming down. The resting energy starts actually coming down. But in burns patients, actually, it just goes up to, I think, 30th or 40th days, what it appears. So it should be somewhere around 3,000 kilocalories on an average is what it would be. Somewhere around 35 to 40 kilocalorie per kilogram is what would be the requirements.
Well, any more questions? Shivali Gupta wants to know, what should be the ideal nutrition requirement for lung transplant after surgery, 20 days?
Oh, this is probably where the dietitian works perfectly here. This is where monitoring works perfect. Once The transplant, everyone does a transplant, the organ takes up and everyone feels very happy, but they are not very, if you see these patients after a couple of months, you'll realize that they are so weak, they can't do half their stuff. So the thing that makes the difference here is actually nutrition. And you must remember that the ball game is lost in the first 15-20 days. What happens is in the first 10 to 15 days, usually when you undergo a transplant, for the first 5 to 6 days, they hardly feed their patients. They hardly feed their patients. In that 5 to 6 days, you are already lost backwards by around 2000 kilocalories. Already more than 10,000 kilocalorie deficit has developed. What we must know is that once there is a 10,000 kilocalorie deficit, then very clearly it has been proven that the overall functional improvement takes more than 6 months. That is the reason that you should start fighting with the transplant patients much earlier on their calorie requirements, and then continue that for a period of around 3 months is what it appears. The ideal requirements for a lung transplant patient is somewhere, because it's a post-operative surgical patient, they will have from day 10 onwards anywhere between 20 to 25 kilocalories on an average, and this is where the averages work a little bit in lung transplant patients.
Again, a very, very important question, Sanjeev. Most of these patients, when they go to the rehabilitation centers where they don't have the indirect calorimetry, and probably most of us would have to just rely on the dietitian. So their question is, how would you, if we have to take a guess, I mean, that's what I would, because indirect calorimetry in a rehab center probably may not be there. What should be your energy requirements?
So here we are again at a guess situation. So once you're in a guess situation, first thing, let us remove whatever we cannot guess. That is, the first thing is the weight. Take the actual body weight in the first place. Okay, if you want to guess some things, but don't guess everything. Even the weight, don't guess. So get the proper weight in the first place. If you get the proper weight, at least you can now guess the approximate requirements in a sedentary individual shall be anywhere between 11 to 20 kilocalories. And most of our patients are actually going to be obese. Most of our patients, please understand this, most of our patients are obese. You may look thin, but when we did our BIA, we found out that a large number of patients have sarcopenic obesity, which means that they look fat, but they have sarcopenia, clear-cut sarcopenia. So in those cases, what we need to give is, we need to concentrate on the proteins very well. So when you concentrate on the proteins, needless to say, the diet will involve lesser amount of calories. You cannot give high calories and high proteins. That is not possible. So on that case, a 20 kilocalorie will not harm in any way. A 20 kilocalorie will not harm, but a lower protein will harm. And that is why a higher protein and a 20 kilocalorie per kilogram actual body weight is what you'll probably look at. And these patients are the ones in which maybe after every 1 week, a BIA, which is much more cheaper thing, which can be done. It can be clearly found out whether you are actually gaining lean body mass or gaining fat-free mass, or you are actually losing muscle mass. No, muscle mass can be easily monitored in this case. Understand this. If you actually give the patient less amount of calories, you are going to lose muscle mass at the rate of even 1 kilogram per day. What we are now data that is coming out in the nutrition journal from our data is that 1 kilogram is lost per day of lean body mass, and that you can figure out by ultrasound. So if your ultrasound at day 5, day 6 actually shows a drop of muscle mass diameter of the vastus intermedius or rectus femoris, whatever you want to monitor, you can clearly say that your probably calorie requirements are much lower than what is supposed to be, and you need to go slightly more higher.
Sanjay, lastly, 2 questions and then we'll close it, right? We're at 8 o'clock. One, how would you feed a morbidly obese patient without indirect calorimetry? And what should be the protein requirement for a patient with sepsis AKI?
So feeding a morbid
obesity without indirect calorimetry.
So most of the morbid obese patients, if you were to actually monitor, we have our subset of patients that we monitored with indirect calorimetry. If you look at that subset, our subset of morbidly obese patients, in fact, I was surprised to see 74% of our patients were actually morbidly obese. They were obese, and a good fraction, almost 17 or 18% of them were actually morbidly obese. So when we actually looked at morbid obesity, that is the only place where you will actually, is the maximally used indirect calorimeter. There is that is the indication for indirect calorimeter, because you just cannot predict in morbidly obese individual. It is not possible to predict with indirect calorimeter. And even if you want to do that, then probably you will use the adjusted body weight plus actual body weight divided by 4. I mean, you use an equation. The problem is to find out the actual body weight. That is the biggest problem. And I mean the adjusted body weight. And we don't know whether the equations that we use for adjusted body weight are right or wrong. So that is the indication for indirect calorimeter. There again, what we know is that hypocaloric diets are what are supposed to be given, but there also it is a kilo per kilogram. It is 11 to 15 per kilogram. We don't know that per kilogram in these particular patients. That is why, if you ask me, I don't have a right answer for morbid obesity without indirect calorimeter. This is the place. Others, all I could still predict something. But in obese patients, you cannot predict. And believe me, we have had patients with 120 kilograms and requiring 900 kilocalories of resting energy expenditure. So how can we anytime predict this? This cannot be predicted in any normal condition. That's why morbid obesity, I don't think there is any way to predict these particular patients.
Protein requirements in patients with sepsis AKI. That was the last question.
Sepsis AKI on dialysis and off dialysis, it should be put that way. So there is no way that you should actually blast these patients with sepsis AKI with proteins. That is very wrong. Some people say sepsis AKI, don't restrict proteins. Agreed, don't restrict, but don't blast them. So don't give them 2.5 grams per kilogram of proteins. You can give up to 1.5 to 1.8 grams per kilogram of protein to these particular patients. Understand, this is sepsis. This is a catabolic phase. Nothing that you do is going to reduce the catabolism. Your proteins are not going to change the catabolic phase. Let this patient settle down, concentrate on his sepsis, concentrate on his AKI. Meanwhile, don't underfeed him, but do not go overboard also. 1.5 gram per kilogram seems to be a good option in these particular cases in sepsis with AKI.
Thank you, Sanjeet. I think, at least I got to learn a lot of things from the session. I am sure that most of the participants would agree with me that, this was a fantastic session and most of us got a lot of things to learn. And I'm sure that one message to all the registered delegates, we did share the presentation last time, on the YouTube. I'm sure the Pulse team would be more than happy and Sajid would be more than happy to share the presentation on the YouTube, and the free link would be provided to all the registered delegates. So let me just get back with Pulse team and discuss this option of where we can share this presentation and the live, whatever has been recorded with all of you. Thank you, Sanjeet. Thank you so much for sparing your time. And both me and Sanjeet together would urge everybody to please become members of ISPEN as well as register for PENSA. An international conference happening in India, a prestigious international event on nutrition in India. I don't think you'll get a better opportunity than this to attend the conference. So request everybody, please visit www.pensa2022.org and register early. Thank you, everybody. Thank you, Pulse team. Thank you, Sanjeet. And I hope all of you have a great weekend ahead. Thank you.
Thank you, Dr. Ghanshyam. Thank you. Thank you, everyone. Thank you.
Thank you, Ghanshyam, sir. Thank you, Sanjeet, sir.
Yeah, all of this is available also on my website. If anyone wants to have a look at it, have a look at the website also, no problem. All the slides.
Fantastic.
Yeah. Okay then. Bye-bye.
Thank you, sir.